All right, it is 12:30, so we are going to go ahead and get started. Thank you everyone for coming. So here we go. Hi, my name is Lauren Law.
I'm Adam Corral.
I'm Courtney Johnston.
I am Dania Quintero.
I'm Owen Stuckey.
And our industry partner is Baptist Memorial Healthcare, and our point of contact is Katie Parker, the Regional Director of Performance Improvement. We are working with Baptist Memorial to reduce their overages on patient length of stay by improving the hospitalist rounding paths and patient assignment. Baptist Memorial Healthcare is concerned that almost half of their patients are staying longer than what their insurance will cover, so the patient are having to pay for those overages out of pocket. Through research, stakeholder interviews, and technical analysis, we have come up with different ways to reduce length of stay. To the right is a spaghetti diagram of the proposed route we have created for the hospitalists to reduce walking time. Baptist Memorial Healthcare was founded in 1912 in Memphis, Tennessee, with only 150 beds. Now, 108 years later, Baptist Memorial has 23 affiliate hospitals, 5 hospice locations, and 4 home care affiliations. Approximately 18,000 people are employed by Baptist Memorial with more than 3,300 beds network-wide to attend to. The picture to the left is a map of all of the affiliate hospitals in East Arkansas, West Tennessee, and Mississippi. Baptist Memorial is known for their excellent patient care and incredible services. There are specialists in cardiology, oncology, rehabilitation, and many others. There is also an entire building dedicated to women's health and care. For our project, we will be specifically focusing on the largest hospital in the network located in Memphis, Tennessee. The picture on the right is a map of the hospital in Memphis. The basement is where the ER is located, with the first floor housing the lobby and offices. The second through fifth floor is for patient rooms with all identical layouts. There are 4 wings to the hospital: the north, south, east, and west.
So the hospitalists are essentially the jack of all trade for the hospital. There are currently 63 hospitalists employed at the Memphis facility. The role of the hospitalist is to discharge patients, request additional tests or scans, and complete daily check-ins to track the patient's progress. There are 2 teams of hospitalists. Each person will work 12-hour shifts, 7 days on and 7 days off. The hospitalist must be well-versed in all areas in order to be able to request the correct tests or specialty doctors. The typical flow of a patient is to first enter the hospital, most commonly through the ER, but they can also have admission orders from a doctor. The nurse will check the patient's vitals and will tell the hospitalist that the patient needs to be admitted. And once a hospitalist officially admits a patient, the new patient will be assigned to the hospitalist with the current smallest patient list. The hospitalist will check on the patient every day and will make requests for tests and or specialists if needed. Once the patient is recovered enough to go home, the hospitalist will officially discharge the patient. Each day, hospitalists visit their patients, and after reviewing their notes and test results from the previous day, they typically go in order from most to least severe, even though this is not necessary. After visiting their patients, they return to their offices to put in orders and make notes, and they typically see a few patients before returning to their offices, which can lead to extended time period before tests are ordered for earlier patients. As of right now, hospitalists are randomly assigned patients regardless of reason for being in the hospital or location of their room. This is causing delays in test requests and patient discharge. This is also making it difficult for hospitalists to visit patients multiple times throughout the day. There's also no set method of which patients should be seen first. This is specifically causing issues for delays in discharging patients because a hospitalist cannot make it to someone's room until later in the afternoon whenever that patient could have been ready to leave that morning.
So as Owen mentioned, most of the responsibility in checking on a patient's condition falls on that day shift hospitalist. And as he mentioned, hospitalists have no standardized way in which they complete their tasks, which leads to a lot of variability among the hospitalists and their respective patients. So from a patient's perspective, they may only see their hospitalist during the morning round that they make. And during that visit, the hospitalist will evaluate the patient's condition and put in any requests or consults for a specialist to come see them. Assuming that that hospitalist is on shift the following morning, he or she will check back in with the patient to see if the condition has changed. The current process of checking on patients during the early morning rounds can be problematic if the patient's condition improves later in the day and that patient now meets the requirements to be discharged. As a result, This can lead to unnecessary extended stays and an increased length of stay. Therefore, our area of opportunity is centered in the realm of improving the scheduling of hospitalists as they visit their patients.
So as Adam mentioned, because the hospitalists only see their patients once a day, patients that are well enough to be discharged after they are visited can't be discharged until the hospitalist visit the following day. This has caused and is currently causing overages and length of stay for patients. These overages then lead to payment responsibilities falling on the patient, or in some cases, the hospital for these excess days. Diagnosis-related grouping, also known as DRGs, are used to determine the observed to expected, ODE, a length of stay in order to determine insurance coverage. DRGs are a system of diagnoses and contain the ODEs. They're relatively universal among hospitals because they are created by Medicare and Medicaid rather than the medical staff at each individual hospital. They take into account the main diagnosis, as well as sometimes secondary diagnoses, necessary treatments, as well as patient age and sex. So depending on the diagnosis, there is an allotted time frame that patients are expected to stay in the hospital following admission. ODE is an average estimate of how long a patient should stay in the hospital, depending on their diagnosis. ODEs are based on historical data and determined by Medicare. They're used by insurance companies to determine who will pay the medical bills expenses when patients receive medical care. Insurance companies use DRG assignment to calculate the cost associated with patient treatment. Any services that used to treat the patients that fall within the ODE will be covered by insurance. And if they fall outside of the ODE, they will not be covered by the insurance, and they're going to need to be covered by the patient, or in some special cases, the hospital. The data used to assess the current system was given to us by our industry partner. It came in the form of a Microsoft Excel worksheet containing patient information from July of 2020 through September of 2020. The data is comprised of categorical and numerical data detailing diagnoses, admission and discharge dates, expected LOS based on DRGs, and the actual length of stay. We were able to sort the data by specialty so that we could focus only on the data that was input by the hospitalist. At Baptist Memorial, length of stay is defined as the time from that you check in to the time that you are discharged. And days are defined from 12:01 a.m. to midnight. Only a hospitalist is able to discharge a patient, but a patient will not leave the hospital right away. A nurse must come in and complete the final steps in order for a patient to leave the hospital, such as remove IVs, finalize paperwork, those sorts of things. You can see here a list of 7 patients with different diagnoses and therefore different ODEs. The actual length of stay is listed in the middle column, and their allotted length of stay, or ODE, in the column to the right of that. The last column shows the difference in these two numbers, which is where our concern is. Ideally, these numbers would be less than 0, meaning that a patient stayed less than their ODE and therefore does not have to pay for any extra coverage. And again, this last column is where we're looking at and where we're concerned.
Thanks, Courtney. So after sorting through our large data set that we received from our industry partner, we averaged the number of actual length of stays and compared it to the expected length of stay for every patient that stayed at Baptist during that 3-month period. And we determined that almost half the patients, or about 48%, were staying over their OTE. The histogram on the left here shows the difference in the predetermined length of stay and the actual length of stay for all patients in our data set. You can see that over 700 patients stayed at or under their OTE by 1.6 days. You can also see here that there are some cases where patients exceeded their OTE by upwards of 20 days. On the right is a histogram of every patient who went from their OTE or who went over their OTE. You can also see here that out of all patients who exceeded their OTE, over 700 patients went over that expected length of stay by less than 3 days, and more than 1,400 patients went over that expected length of stay by less than 5 days. This is important to note because while there are a large amount of patients exceeding their OTE, a majority of them are only doing so by a few days. After performing this analysis, it became clear that if we could create a system for the hospitalist that could decrease patient length of stay by even a day or two, it could drastically decrease the number of patients that are going over that OTE, and that would save the hospital and patients time and money.
To obtain more knowledge and look for potential solutions to the length of stay overages of patients at Baptist Memorial, and external research from a scientific analytical institution was completed. The theories established by LINTAS included 10 possible causes and solutions for this problematic. After being compared these theoretical causes with the current hospitalist working approach at Baptist Memorial, we concluded that at least 3 of these causes have possible connections. Patients' rooms was the first related concern found. LINTAS theory explains that the lack of a consistent approach when assigning patients to rooms could have negative effects, such as slow patient recovery and additional clinical complications. Next, the transitioning of patients from the emergency room to individual rooms could be another reason for the problematic phase. To explain, facing some delays when transferring a patient from the emergency room to his or her target room could generate additional complications in that patient's current health condition. The path of completion of hospitalists when carrying out daily visits of patients was the last related concern found. This analytical institution theory explains that there is an existent and common variation when hospitalists complete this process. While some of them complete their roundings at the beginning of the day, others prefer to do this at the beginning of the afternoon, delaying patients' discharge procedures or even additional completion of tests by patients in early morning.
So the exact causes of these length of stay overages is unknown, but through many interviews with Katie, we have come up with several possibilities displayed in the fishbone diagram. To preface, these are all theories that we have come up with. In the category of personal influence, we have specialists, nurses, and hospitalists. Specialists can get very busy depending on how many specialists are available in one specific area. They are in high demand, especially when a patient's diagnosis is unknown. They could be staying in one patient's room longer than anticipated, causing them to get behind in their schedule. Nurses are the glue that hold hospitals together. They can also get very busy, causing them to get behind schedule or complete a task later than expected. Hospitalists are the only people who can officially discharge patients and therefore are one of the largest controllers of a patient's length of stay. Even though hospitalists have a list of tasks, there is no standardized way in which to complete those tasks, as we mentioned before, which can be causing an inconsistency in length of stay. In the category of environment, we have personnel being stopped and patient room placement. Like any other job, people who work together tend to share events and stories from their personal life and have normal conversations with each other. While this is good for morale and bonding, this can cause distractions and delays. There are little to no reasoning for patients being placed in a particular room. This can cause hospitalists to be walking all over the hospital to visit all of their patients. In the category of machines, we have delay in tests and scans as well as delays in those results. These reasons go hand in hand. When things get busy around the hospital, there can be delays in getting a test or scan completed, which can therefore cause getting the results later than expected. This can cause length of stay overages, especially when the results of a test or scan is the determining factor if the patient can be discharged or not. In the category of measurements, we have DRGs, ODEs, and length of stay. Because DRGs and ODEs are controlled by insurance companies and not by the hospital themselves, we are not sure how often they are being updated to be in conjunction with current medical procedures and practices. This could mean that the DRGs and ODEs are inaccurate to some extent, causing unnecessary overages for patients. The actual measurement of length of stay could also be a factor in overages. Like we mentioned before, a new day starts at midnight. This could mean that the patient who are admitted later in the day or evening are paying for an entire day of care as opposed to a full day of care when they could be receiving less than 4 hours. In the final category of method, we have how hospitalists are being assigned to patients and the order in which those patients are being seen. New patients are assigned to the hospitalist with the fewest patients in his or her care. This means that the diagnosis and room placement have nothing to do with which patients are assigned to which hospitalist, possibly causing the hospitalist to walk all over the hospital in order to visit his or her patients, resulting in unnecessary travel time. Hospitalists typically visit their patients from most to least severe. This could also be causing unnecessary travel time. By creating new paths for hospitalists to visit their patients, we can reduce walking time and therefore length of stay.
Thank you, Lauren. So as we were looking further into the hospitalist travel method, we were able to set up and conduct a stakeholder interview with one of the head hospitalists for team health at Baptist, Dr. Quintero. Dr. Quintero was very helpful and open with us, and we were able to clear up some of our assumptions and also learn more about hospitalist day-to-day duties. Here you can see 6 key takeaways that we gathered from that meeting. We asked about some factors that can affect hospitalist time and efficiency, and we learned that the biggest factor in hospitalist efficiency is the communication skills and characteristics of the hospitalists themselves. For example, one hospitalist may talk to a patient about how their day went, while another hospitalist may just stick to the script and move on quickly. This information is key just because it does provide, or just does prove that we are dealing with human factors throughout this project. Also asked about the different approaches hospitalists have when planning their day. He said that some will check all their patients' charts before beginning their rounds, while others may do this simultaneously. One opportunity of improvement that we are looking at is the order that patients are visited. And we learned that many hospitalists will visit all of their new patients that they've received that day first before moving on to the patients that they are more likely to be released soon. We also learned that currently Baptist does not have a geographical method to placing hospitalists throughout the hospital. You mentioned that implementing a hospitalist placement planning system is something that they would really like to pursue. Lastly, we wanted to discuss how hospitalists manage their frequency of visits with their patients. Dr. Quintero said that he used to work in a smaller hospital and was able to visit all of his patients multiple times during the day, even with the same amount of patients that he manages today. He said that many of the hospitalists would love to visit their patients more frequently throughout their day, but because of the long walking distances in the Memphis facility, they are often unable to do so. And quality of care is highly emphasized at Baptist Memorial, and this is why we are looking to try to standardize a method that the hospitalist follows so that they are able to visit patients more often.
So we wanted to look and see if there was any statistical evidence for any of these cases that we have seen. And the first thing we looked at was we wanted to know if the diagnosis had an effect on overages, even though that is something out of our scope. If we discovered that a few of the diagnoses had the majority of the overages, we would have thrown out those diagnoses since it's something that we can't change. And that would skew our results negatively and not allow us to see the actual problems that we can solve. And we, just didn't want to focus on things that we couldn't change. Secondly, we wanted to know if the hospitalists had an effect on the length of stay. If there was one that consistently had patients staying under their ODE, we might want to look to see what they are doing differently to see if we wanted to translate that to the other hospitalists. Vice versa with a hospitalist whose patients were frequently going over. We might investigate to see what they are doing to negatively affect length of stay. To check for statistical significance, we found the difference between length of stay and ODE for each patient. We averaged these numbers for every hospitalist and diagnosis and used Minitab to run a one sample t-test on both the hospitalist average overages and the diagnosis average overages. We found both the p-values to be low, meaning that we would reject the null hypothesis that assume that both factors do have a significant impact on patient length of stay. Once we found out that these did have an impact on length of stay, we began to investigate further. One issue that we found during our investigation was that we didn't have much data, especially for diagnoses, which meant we couldn't really reliably compare one diagnosis to another. To remedy this, we attempted to combine similar diagnoses so that we could get a large enough sample size to run more statistical analysis. We then looked for any major outliers. For instance, we found that the ODEs for COVID-19 patients were not very reflective of their actual length of stay. And we found that they frequently went way over their ODE. Once we removed these major outliers such as these, we found that the ODEs were actually a pretty good predictor and laid pretty close to the actual length of stay average for the diagnosis, which is, what the insurance companies are aiming for. So while it was good to find the major outliers, we found that once those were gone, the diagnosis didn't have a significant impact on length of stay or ODE differences. We also found that the hospitalists who had higher average overages tended to be treating these patients with the higher average overages. So our industry partner suggestion, we quit investigating further.
Thanks, Courtney. So we also have done some analysis or did some analysis over the past semester that has been very helpful in understanding what affects patient length of stay and what may be causing the overages, but will not actually be used in our final implementation. Ms. Katie Parker, our industry partner sponsor, informed us that while she does want us to improve length of stay through the hospitalist efficiency, she also wanted us to analyze specific diagnosis and find any trends with the length of stay with those. And here you can see a table showing analysis for patient overages for all diagnoses with at least 30 cases. The purpose of this analysis was to determine if there were some diagnoses where patients were exceeding their expected length of stay by a substantial amount. If this was the case, that would mean that the overages are unlikely caused by the hospitalist and rather an issue with the DRG calculated OTE. So we sorted and filtered through the large data set that was given to us, and that data set did include patient admissions, including their diagnosis, expected length of stay, and actual length of stay. And we were really trying to dig as deep as we could into this data to fully understand all the factors that affect LOS and to determine which specific ones we can improve. In this table, you can see the diagnosis, the number of patients in our data with that diagnosis, the percent of those that stayed over their expected length of stay, and of those, the percent that stayed over by only 2 days. We chose that 2-day range because at Baptist, a patient could be admitted really late in the day, but if that time is before midnight, they're considered to have been there for a full day. As we talked about in the past, there were almost 50% of patients with overages from the entire data set, so it was not surprising to see the percentages in that overage column in the middle. What we really wanted to look at and see was the length of stay overages for each diagnosis shown here in the far right column. As you can see, the diagnoses at the top highlighted in green have a high percentage of patients that only stayed 0.5 to 2 days longer than their expected length of stay, meaning that there is a possibility of improvement for the hospitalists in these cases. However, as shown in the red here, there are also 4 diagnoses that have less than 30% of overages in that 2-day range. This could be an indicator that the DRG calculated OTE was not an accurate predictor for length of stay in these in that 3-month period for those cases. So after performing this analysis, we were able to focus more on the diagnosis that had more patients only staying over by a few days, determine the causes for these overages, and then recommend changes for in the hospitalist improvement for the rest of the cases. After all, even improving the length of stay by just a day or two, as I said before, will save the patients in the hospital a lot of time and money. While we did stray from looking specifically at the diagnosis, this analysis did give us some great insights on the many causes of patient overages and will be something that we definitely want to, that the Baptist definitely will want to look into in the future.
Due to high variation and lack of consistency in results from past statistical dataset studies to establish possible causes and solutions for these length of stay overages, the team decided to change the project scope from a capstone design project to a more traditional IE project. To explain, we were interested to implement a plan that could provide improvements in hospitalist rounding path and patient assignment when completing their weekly roundings on patients. To do this, an Excel file containing data of a specific weekly hospitalist workflow was provided by our industry partner Contact. The information included patient's note date, note time, note type, for example, progress notes, discharge summary, and sign-off note. Also, we could receive patient's ID number, room number, department type, patient's admission time, discharge time, and discharge type. For example, home, transitional care, left against medical advice, and expired. Because most of the categories in this Excel file provided non-numeric variables, we decided to focus on patient's ID number, note time, and room number. So this is the list of patients that Dr. Santiago went to see on January the 15th and 18th of 2021. We used this as a starting point when creating and completing the proposed plan, which will be explained later by my teammates.
So using the data from January 15th, we mapped the walking path of Dr. Santiago. Shown is a spaghetti diagram that includes a different color for each floor. Also, at the 2 elevators highlighted in blue in the center of the hospital, we added a marker to show how many times the elevators were taken, which was 4 times apiece. And this means that he changed floors 8 times throughout the day. We had to make a few assumptions to do this, one of them being that they used one of the 2 sets of staff elevators to change floors. They could have used stairs or whatever, but, we just needed to have this. For the diagram, we also decided to have them travel back to their office when it made the most sense to us, even though that may not be the case in reality, but this will be discussed in the next slide. For this scenario, he returned to his office highlighted in green and marked with a red dot 5 times. This diagram shows just how much wasteful time there is in a day. Since doctors tend to follow the heuristic of seeing patients in order from the most to least severe, this does lead to a lot of travel time back and forth between areas, not even including the trips back to their offices. You can see here that you can't even see all the paths he's taken because they cover each other up. But this diagram really did show us that the hospitalists are not using their time effectively. The travel between patients is all over the place, and the hospitalists might even visit the same hallway twice if they are visiting in order of severity. They also change floors many times throughout the day, which we found to be a big contributor to increased travel time, since they do have to walk from a patient to an elevator and from the elevator to the next patient. Many times throughout the day. And we also can see just how much extra walking time is needed for them to return to their offices. And while this is just one doctor on one day, we believe that every single hospitalist has a similar order or method.
So with the information that Dania and Courtney just talked about, our team is interested in calculating the walking distances and traveling times for Dr. Santiago's 16-round process, which, as Courtney mentioned, he traveled from floors ranging from the 5th floor to the 2nd floor. It's important to say that we made a few assumptions due to the lack of overall data, and we decided to use an average walking speed of 5.5 feet per second. And we were able to get the exact dimensions of the hospital hallways and floors due to a blueprint that was sent from our industry partner. So from this data set, we knew the order of visits that Dr. Santiago took, but we didn't know the number of patients he saw before heading back to his office. So we decided to divide this analysis into 5 categories, which include the different amount of patients Dr. Santiago could have seen, ranging from 1 to 5, before going back to his office. For example, in the first row, you can see that the time and walking distance it took to visit one patient and head back to his office ended up being about 15,300 feet and had a total walking time of 56.36 minutes. The same approach was made for the rest of the categories, with the only variable changing being the number of patients he saw before heading back to his office. What does this analysis show us? It shows us that the completion of 5 patients has the smallest walking distance, but rounding on 4 patients and heading back to their office may have the smallest walking time. But since our goal is to reduce the overall travel distance rather than the time spent with the patients, the completion of rounding on 5 patients before heading back to an office seems to be the best choice.
So in order to determine the possible improvement, we have recreated Dr. Santiago's walking path with patients in 2 wings with 2 hallways each, as well as computer workstations in each wing for the hospitalist to use. These implementations will avoid the back and forth movement between hospitalists, their patients, and their office. This is the proposed design with the additional implementations. We've also assigned the hospitalist to 6 patients, with 4 patients in the north wing and 2 others in the east wing, allowing us to use our walking path to actually see the possible improvement. At the same time, we have established these hospitalists to see all 6 patients on one floor level prior to moving to the next. We realize that some patients have more severe diagnoses and require more intense care than others. But if a hospitalist could see all or most of the patients on a specific floor level, he or she could avoid that back and forth movement and decrease walking distance. By applying these additional improvements, we got a total walking distance of 2,670 feet. By comparing these with the best case scenario on the previous slide, the hospitalist could save 6,470 feet in 26.6 minutes. In conclusion, the difference could be spent to complete additional patient visits.
As Dania and Owen previously mentioned, our team was forced to pivot to a more lean-based approach due to the lack of uniform variables and general variability amongst the data that we had. We wanted to consider a variety of other methods to improve some of the non-value added processes within the system. And after talking with our industry partner, we decided to use the CATA method of continuous improvement based on the conversations that she was having with hospital management. The Toyota CATA method is a process improvement technique that was originally developed to eliminate waste in manufacturing processes. However, we found that the techniques and principles in this process are applicable to industries such as healthcare. To begin, we start by defining the target condition, which we've laid out here to be decreasing the patient length of stay by half a day. And then from there, you assess the current system performance, which is something that we did last semester. After this, like any other scientific method, you begin conducting experiments that'll help you attain your target condition. And at this point in this presentation, we've talked about eliminating waste by improving the rounding process hospitalists use in rounding on their patients. After this, you analyze the results of these experiments, and if this experiment puts you one step closer to your target condition, you can continue to make other necessary improvements that'll help you get there. If the results end up pushing you further away from your target condition, you learn from those mistakes and you adopt changes as need be. We're using the CATA method because it really emphasizes on learning from the failures of each experiment, which is something different than other processes like Lean Six Sigma. So think about it as just another continuous process method where if you don't move closer to your target condition by the end of the day, you'll be equipped with the information you need tomorrow to make changes in the right direction. Once we were able to implement this continuous process method, we then analyzed several improvement ideas and ranked them according to what we believe will yield the most positive impact at Baptist Memorial. Based on the evaluation of the current system performance and stakeholder interviews, we decided that the biggest opportunities are in the areas of improving the hospitalist rounding paths, adding computer carts and workstations, and improving the geographical assignments of hospitalists to a designated area in the hospital.
So this table depicts our final recommendations that we are giving to Baptist Memorial. With the highest degree of priority and most likely to make a drastic difference is the geographic assignment of hospitalists and having the hospitalists use the nearest neighbor heuristic to visit all of their patients. For the geographic assignment, each hospitalist will be assigned a wing, which has 2 hallways of patient rooms that they will be over. Patients will be given a room when they are admitted, and whichever hospitalist is assigned to that wing will indeed be the patient's hospitalist. This differs from the current method because patients are randomly assigned a hospitalist regardless of room assignment. Once a hospitalist is given a wing and a patient list, we will then recommend that the hospitalist pick a starting patient and then use the nearest neighbor heuristic to visit their remaining patients. This will decrease the walking time between patients and possibly decrease the length of stay of those patients. We will also recommend that their starting patient is their healthiest patient to try and decrease the waiting time for that patient to be discharged. The next degree of priority goes to adding workstations to each hallway in order to reduce the number of times a hospitalist goes back to their office. These would be similar to nurses' stations. There would be a station with a computer that is able to fill requests and input data by using the ID all hospitalists and staff must wear. On the lowest priority is providing computer carts for the hospitalist to input data and request. This would be a cart that a hospitalist has with him or her at all times in order to fill requests and input data. There are some challenges that come with this idea. It can be a hassle to wheel the cart around everywhere you go, and finding a power source can also be difficult. Also, making sure that the laptop is charged throughout the day can be inconvenient. After we give these recommendations to Baptist Memorial, it will be up to them to implement them. We have already heard from Katie that they are planning on adjusting the assignment of patients to hospitalists and the order in which patients are seen.
To summarize, our project goal was to decrease the length of stay overages of patients at Baptist Memorial by improving hospitalists' rounding path, and patient assignment. To complete our goal, we focused on healthcare employees, doctors called hospitalists, whose duties include patient submission, patient discharge, and the solicitation of tests and additional care of specialty doctors. A dataset study utilizing current data from Baptist hospitalists and patients demonstrated that for almost half of the patients, the length of stay exceeded the ODE put in place by the DRGs, causing some financial problems. By the implementation of traditional IE techniques, a proposed plan was created to improve hospitalists' path of completion visits using the closest neighbor heuristic of the most efficient path to complete the rounding procedures. Additionally, several recommendations from the most to the least important was provided to Baptist Memorial. Looking to bring a more efficient and consistent hospitalist rounding path, we made emphasis to patients' geographic assignment, closest neighbor workstations, and computer cards. It was an excellent opportunity and experience by our team to work with Baptist Memorial Healthcare during the past months. Thank you to faculty advisors and Katie Parker for all the support you received through this project. Likewise, we want to thank this audience for being present during our final senior capstone presentation.
And Katie has a few words that she would also like to say. Katie, go ahead.
Thank you. First, I want to say thank you to this team for the great work they did. As far as the work they've done, what we are going to do with this work is take this work specifically around the geographical rounding back. We are currently looking for units where it does make sense for us to implement this geographical rounding, and the data that they have given us around how it saves time and steps, we are using that to help sell our the idea of geographical rounding for those involved in that. There's other clinical reasons too why we want to go after that, but the information provided by this team will be very helpful in that implementation. So we look forward to that.
Awesome. Thank you so much, Katie. And the floor is now open to any comments, questions, concerns that anyone would like to ask.
Hey, I have some questions for you. First, I want to say thanks to Katie for giving this great opportunity to our students. We appreciate your relationship with the department. I'm really interested in the piece about the DRG ODEs and the relationship between those estimates and what turns out to be length of stay. When you're under and overestimating length of stay, who bears the financial burden of that? Is that shared between the patient and the hospital, or is it falling mostly on the on one or the other?
Any overages that is not covered by insurance are put on the patients, other than very specific 1 in a million chances, but 99% of the time it's the patient paying for those overages.
So would you say that the underestimation of length of stay is a nationwide problem or not?
Go ahead, Courtney.
Most likely, yes, it is. It is an average. And if you look, it is actually about 50%. And, even though that's the average, Baptist really would like to, half of their patients are having to pay extra. And so Baptist really is looking at decreasing the number of patients that have to pay extra. But since, again, it is an average, we are assuming that this is probably a nationwide problem.
So is this differential something that that hospitals pay close attention to? And even because if I'm in competition with a hospital across town and I can demonstrate somehow that the differential between ODE and length of stay is is like best in class, and that would be beneficial, I think. So how close, I know it wasn't the focus of this project. How closely do you think hospitals are paying attention to this? Or are there like patient advocacy groups paying attention to this?
So this is kind of like an elephant in the room, because these financial burdens aren't placed on the hospitalist. Sometimes as soon as a patient's discharged, you're moving on to the next patient.
Right.
So I think this was something that Baptist kind of found out of the blue. And they've realized that this is a problem and this is something that they need to fix, because quality of care is so important to them, and that financial burden is, you know, decreasing that quality of care that Baptist wants to give them. And so they want to adjust, because Baptist themselves cannot adjust the DRGs and ODEs because that's placed by insurance. They're trying to control what they can control within the hospitalist and testing and patient assignment to decrease the length of stay using factors they can control.
And
Yeah,
there's
I think you were,
definitely,
go ahead, sorry.
there's definitely a lack of research done in this. You know, we were able to find research, and Dania discussed some of the research, but there really hasn't been much, especially academic research done on this. So at least academically, it's not being looked at very much, because you know, some of these hospitals are just concerned with getting patients and getting them better, and may not necessarily be looking at the economic burden. So just because of the lack of information and research, I'm assuming it's not being looked at a bunch. But, you know.
I think you uncovered something really interesting, and I think you were smart, especially within a hospital. I think it would be important to see if there were certain DRGs that were prone to over or underestimation.
Yeah, that kind of
because
goes back
I
to-
may be particularly good at something that you aren't, and vice versa. And so I wouldn't assume that if I'm over or underestimating something, and I know I'm not doing it, I'm taking the forecast from some other system. But if my lengths of stay are systematically exceeding the ODE for certain DRGs, I wouldn't assume that would be the case for you, for example. Anyway, thanks for the presentation. I enjoyed it, and congratulations on a successful capstone project.
Thank you so much, Dr. Jimka.
Thank you.
Are there any other questions?
Are no more questions, I think that concludes our presentation. Thank you everyone for coming. We would also like to invite you to our poster exhibition. It is the other Zoom link that is attached to the symposium website that will be open till 4 p.m. We'd also like to invite everyone to the awards ceremony tomorrow at 3:30. That Zoom link is at the top of the symposium website. There will be individual awards, team awards, as well as industry partner awards. So thank you all for coming.